Mark had said, he read the article and he said, we need to do a presentation on this. This would be great. A great topic, and oftentimes it's the caregiver. You know, we get so inundated with our patients, we get so focused on them that the patient's caregiver often is the invisible patient. And so there was a couple of articles, well actually there was an article that really prompted, and I'm going to go on and get started. But I had, let me just preface before I get started, I had a lot of anxiety about presenting to you all. I really did. And because when I come to these presentations, they're always pretty technical. And I always feel like, well, as a nurse, you know, I'm not really on that type of level. When you start talking, you know, more specific about disease processes and things like that. Although I can have that conversation, you know, when it comes to caregiving, it's a little bit different. So I didn't go through a lot of the review of literature and things like that, because I realized I needed to be true to myself, and I needed to be true to you all, and what would be the most beneficial for you. And the most beneficial is to just speak practically and how you can be the best assistance to your patients, okay, and their families. So that's where I'm going to be coming from today. And then at the end, I'm going to kind of speed through it. If you would like a copy of this presentation, just contact Joe, and Joe will be more than happy to get that for you. But you know, I really want you to get to the end where we have an interview with an actual caregiver. Okay? Yes, ma'am.
I just wanted to say thank you for presenting to us, because you have an incredible perspective as a nurse that none of us have. And I'm very happy to hear from you, and I know I speak for all of the other fellows in saying that.
I come on in. You know, I appreciate that so much, and it really kind of validates, because, you know what, I don't see, you know, we're as a team, all of us bring something to the table. You know, it's like a potluck, and I have that in the slide presentation also. You know, we all bring something different, and so that makes us very much colleagues, because I will look at it from a different perspective, and not that the perspectives are wrong, they're just maybe a little bit different, and it all works good together. So I appreciate that. I thank you for that. Okay, so Joe, I guess we can't dim the lights anymore, can we?
Is that too dark?
Is that too dark, Joe, or Mark to present a little bit?
It's fun.
Okay. So, the invisible patient, we want to recognize and treat the caregiver burden. Let's move on. And I think you guys have already seen what the objectives are, is to identify the caregiver as one of the most prevalent conditions among those caring for loved ones with dementia and chronic illnesses. And you'll see the significance of that in a moment. Describe characteristics of an invisible patient and why it's important for you to identify him. Discuss your role and responsibility to recognize the invisible patient, and you do have a responsibility. Interventions to mitigate caregiver burden and related caregiver stress. So what's coming? Why are we, everywhere you turn, now, it used to be the dementia thing. Now it's the caregiver thing. And why? Because we have 10,000 people turning 65 daily. And in time, who's going to take care of all these people? Who's going to take care of them? You know, the silver tsunami. We talk about this voice crying in the wilderness that a storm of seniors are coming. They're here. They are already here, starting to inundate our healthcare system. By the year 2030, an estimated 20% of U.S. population will be 65 years or older. 10% older than 65 and 47% older than 85 are projected to have dementia. So that, we know that is a growing problem. It's growing. 80% of persons with dementia are cared for in their homes by family members, and 21% of the family members in the family practice study had caregiving responsibilities for persons with chronic medical conditions. So, you know, you've got, not only do they have dementia, but they have other comorbidities that are going on with that, and it's very much problematic. So who is the invisible patient? And I thought this was really pretty creative. When I started putting this together, I said, wow, what about the invisible man? But most of your caregivers, 60% of them are women. Now that the men are growing, 40% of the population of men are now caregivers. So, you know, they're kind of catching up. Now, the invisible patient, you might think they come into your office and they might look like this. But in reality, this is how they might feel. And I thought that this part of it was really pretty interesting because, you know, what you can't see are the worries, the problems, the doubts, and the stress that they experience as they are caring for others. And, you know, this picture right here, this one here, and this one here are classics, you know, because sometimes you just want to go in a corner and just die. When you read and I didn't want to take the time to read it, but it's a very interesting, on the front of this caregiver burden, a clinical review, there is a patient story on it. And that patient story describes a caregiver that tried to commit suicide, actively, with a gun. She didn't kill herself, but she was taken out of that position of caregiving, which was extremely stressful. And you know, all the warning signs were all around her family, and the family was just too blind to see. She went to the doctor, and the doctors and the nurses and everyone thought she was okay. So it's really a problem, and we have to not be myopic in our vision when dealing with families when they have a sick care one. It makes it worse when it is dementia, and we'll see that in a moment. Caregiver facts. 44 million adults are providing personal assistance for family members with disabilities or other care needs. And it costs people an annual, look at that, $522 billion annually. Now, with what I call these are the new undocumented workers. You know, they're not coming from Mexico and other countries, they're right here. You know, these caregivers that are giving all of this care, undocumented. No real support. 22% of caregivers are caring for someone with Alzheimer's or dementia. The caregiver today may be the adult child caring for a parent holding a full-time job. They're no longer parents caring for children or babysitting somebody else's kids. They are babysitting their own older family members or a child with disability. Caregiver facts. They perform 2 daily activities of daily living. They are involved with 4 instrumental activities of daily living, and they're doing medical nursing tasks at home. This is what, you know, they have this new program coming up called Hospital in the Home. They've already been doing it. The hospital's been in the home for a while. Caregiver facts. Higher hour caregivers' average time spent providing care is 62 hours per week. And those are the higher hour caregivers, which means these are people that usually live there. And they're providing care all the time, 24 hours a day. 40% of caregivers report a high burden of care. Only 18% report a moderate burden of care. Well, your caregivers today are a lot older. You know, now you might find them 49, 50 plus, but you find so many more caregivers 75 and older. Nearly 1 in 10 caregivers are 75 or older, or approaching that. They are the sole provider of care and usually live with the care recipient. Those ones, like husbands, wives, they are also high-hour caregivers. The nursing tasks performed, and I already said that, the injections, tube feeding, catheters, colostomies, many other complex care responsibilities they're responsible for. So because even if a person is on hospice or palliative, they go home. They're not in the hospital. And a lot of these people have never been trained. So it's OJT. When caregivers were asked if they had a choice in their caregiving role, half of them said no. And some of it is cultural. You know, whoever's the youngest. If you're a woman, even if you're the youngest, if you're male, it's not your job. It's going to be the youngest female. Now, this is my guy, Dr. Ronald Adelman. He was the chief of geriatrics at Cornell. He was the one that Jane Gross actually she attended his presentation on his clinical review, and that's, you can find that in the JAMA, and I passed that out to you. Jane Gross wrote about him, and then I read her paper and wrote about both of them, you know. But that was more focused towards the caregiver, because bringing it to their attention that you might be an invisible person. You've got things going on, and we are calling that caregiver stress, caregiver burden, and that is a term that you need to be familiar with. And you need to be able to identify your stress, because we don't want you invisible. We want you to be able to start talking about what's going on with you. What do you need help with? Because no one can help you unless we don't know what you don't know. So that's, but anyway, all three of those articles are available. I did not print out Jane Gross's article, but you can get it. But I did print out mine. So what is caregiver burden? And we've seen that multi-dimensional response. I mean, we got all these technical definitions. A multi-dimensional response to negative appraisal and perceived stress resulting from taking care of an individual, an ill individual. The extent to which caregivers perceive that caregiving has had an adverse effect on their emotional, social, financial, physical, and spiritual functioning. That really is a mouthful, but it says it really kind of encompasses all of those areas that are impacted by caregiver burden. Caregiver maladaptation to caregiving demands. You know, you just can't handle it. And then, this is caregiver burden according to me. The amount of stress we experience increases, which you have no control and no help with. The stressor becomes the burden. You know, and I just thought, that's a simple way to kind of describe it. So, Valerie Taylor, 2015. Why should you be aware of caregiver burden? Because of the negative consequences. There are negative consequences, and the caregiver activities are very stressful. And as you can see with the negative consequences, it affects everything. All of their areas of being, it affects. The caregiving activities are stressful because a lot of times they're complex, they're physically challenging, they're time-consuming, they're emotionally difficult, but they wear on the body. There's a lot of wear and tear. And especially when you have an HIH in the home, a hospital in the home, you are moving these people, you are picking them up, you're turning them, you're changing diapers, you're doing all of these things that are extremely stressful to your body. So that's why. Risk factors for caregiver burden, being a woman, and we identified that. Around the clock care, that 24/7 duties. You're dealing with chronic illness care, dementia, cancer, decreased functional status, end-of-life care. Any of those things are extremely difficult. Complexity of medical tasks, transitions from the hospital to home. Now you're dealing with something different. You know, when they left to go to the hospital, they were one way. Now, after surgery on a hip, they still have anesthesia that's bothering them, and so they're not quite back to normal, okay? So they may be exhibiting some cognitive problems, which have been grossly impacted because of the surgery that they've had. Financial stress, less caregiver education really impacts it as well. The social isolation. And then, you know, one of the things that most of the caregivers that I've interviewed have a real issue with besides the dementia is the incontinence. You know, the incontinent stool, urine, I mean, just keeping these folks clean is such a burden, you know, on them. The falls, you're constantly feeling paranoid. Can they they're getting up at night, and so are they going to fall? Most of your falls occur in the middle of the night, say 3 or 4 o'clock in the morning. They're hard of hearing, so they're having to repeat themselves over and over again. And thankfully, Dr. Powers is here to give them pocket talkers, you know, because they will not wear hearing aids, you know, because it's difficult to try to adjust those for them. And so, you know, you've got just a whole lot of stuff going on. So we're going to move on to the next one. Why should I be aware of caregiver burdens? Because the caregivers are taking care of your patients. You know, that's the bottom line. If they fall through the cracks and they begin to really get sick, and if they get sick and die, that person, if they don't have anyone else to pick them up, they're going to be knocking on our door. You know, so the best thing to do is to try to keep them healthy as possible, so that will enable the person to stay at home. The clinical goal is to lessen caregiver burden effects by early detection, using caregiver assessments and appropriate intervention. The result of early detection and intervention is keeping the patient at home longer, decreasing burden for caregivers in the healthcare system. So that's what Okay, so here I was trying to share the fact that you as physicians, you are the great collaborator. You know, on your teams, you've got a lot of access to different types of people. You know, I know that with our Geriatric Connect, we have a social worker, we have a geriatric pharmacist, we've got a social worker, we have access to dietitians, we've got access to audiology. We've got, being in the VA is such a wonderful place to be, because we've got a lot of different resources that are available to us. Some of you may leave here and go into private practice, and you may not have the resources all under one roof. But, you know, that's why it's important that you form alliances with other people. Know what your team needs to look like, and you can do that by picking up on that from here. But you play a role in the assessment also of the caregivers, often in collaboration with social workers and nurses. But you're the frontline worker. More than likely you are, because you spend the most time with the patient and their caregiver. You have the ability to identify factors that may be causing distress related to the course of the disease process. Your observation and assessment make it more objective and concrete than subjective, because the patients will come in and say, well, this is bothering me and that's bothering me, but you have, because of your assessments and all, you can form that into something concrete, and then disseminate that within, you know, your social workers or your nurses or whatever, and you can get some scoring going, and you have a better picture of what needs to happen with that client. Now, I'm not saying that every person that you talk to has to be a research project. I'm not implying that at all. But, you know, for you to have an idea of what needs to happen, what direction they need to be pointed in is extremely important. Therefore, caregiver needs need to be evaluated on an ongoing basis, and especially as the caregivers or the patient's needs change, or as they advance in their disease process, whether it's cancer or as it changes, like when now they're in stage renal disease, or maybe they're on hospice, or is it time for them to go to hospice? So what are the types of issues may arise as their condition is changing? So that means that the caregiver's needs might change as well. Form a relationship with your families. No, you can't do it all, but you have a team, a network of resources to keep the caregiver visible. Okay, now, going to slide, you have a copy of this one, this JAMA network. This is something that you all can take with you so that you can read, and it will give you an idea of, did everybody get that one? That was the JAMA network, okay? This is really kind of, it talks about what you must acknowledge. First you have to acknowledge the seriousness of the potential for the caregiver. But this form here has different questions outlined, and I just kind of gave you the topics. You know, the relationship to the care recipient. from that, the questions that are outlined on that, it provides information on the dynamics between the caregiver and the care recipient. Because sometimes, you may have a caregiver that is a reluctant caregiver, or they're a caregiver, wanting to punish this person, because they were not a very nice person when they were married. Maybe they were an alcoholic, or maybe they were an abuser, or, maybe they had some issues. Maybe they didn't. But if they did have those issues, you might want to know about that, okay? And be aware of it. Quality of family relationships, self-identified quality of relationships might correlate with higher burden levels. What if they don't have family members that can help them? Or maybe they do, but they're just not interested in helping. So they're a caregiver by default, and no one's there to help them with anything. And so you've got a caregiver with a lot of resentments. And a lot of older people, you'll hear them say, I don't want to ask my kids. I don't want to bring them involved in it because they've got their own life. And my thoughts are, they took time out to raise you, so there's something that they should be able to do. So maybe a family conference might be warranted. Physical environment, caregivers who live with the recipients tend to provide more care. So you'll want to get a handle on that too. Are they living with them? And more than likely they are. How are they taking care of themselves? Duration of caregiver. Longer duration of care is associated with a higher likelihood of burden. Financial and employment status identifies a financial burden. Some people decide to, I'm not working anymore. And or they're taking off too much time. At any rate, all of that is impacting them financially, and it's causing a burden. Household status, are there any additional caregiver stressors and potential resources for support? So all of those areas, all I did was just kind of identify, the areas that he had spoken about in that. Now there are three, I hope you all picked up the three surveys that we use these ourselves. The neuropsychiatric inventory questionnaire, the NPIQ, the caregiver burden of chronic illnesses, and the Geriatric burden. The NPIQ is to obtain information on the presence of psychopathology in patients with brain disorders. It was developed for the application to patients with dementias, but it is also used to measure the amount of caregiver distress, because they have to rate. If they've got any of those, like the agitation, do they have, I can't remember, talks about hallucinations or agitation, depression, anxiety. If they have any of those, and you can certainly pick those up, the rating, then there's some additional problems that they have on the back, like if there's wandering, sweet cravings and things like that. Any of the additional problems that may be going on, they can identify, but it also has the severity and the distress, not that the patient receives, but what they do. So you're measuring the caregiver's amount of distress that they are feeling. And that was Dr. Jeffrey Cummings that had done that. Okay, the caregiver burden of chronic illness, this is what it looks like. And they were asking them to rate if they have any of these comorbidities. Okay, the high blood pressure, diabetes, chronic pain, congestive heart failure, dementia, anxiety, general old age, anything that they have that we didn't mention. Okay, and then they get to rate those. If they don't have it, it's 0. If it's not at all, up to a scale from 1 to 5, they're to rate these. And this was Dr. Polly Noel, who's here. We all know Dr. Polly. She modified this from Elizabeth Bayless's, and so what we did, we added dementia on it, and there was something else she had added. But what we found, we only had a small study, but what we found was in the chronic conditions associated with the highest report as caregiver burden was cognitive. And that goes along what they're finding even out in with larger samples. The dementia, most caregivers, when it comes to dementia, that gives them the highest burden. And why would you think that?
You're watching them all the time. You have to make sure that, everything. You have to watch everything just to
That's-
make sure that they're
Absolutely. You know, and that's one of them. But the other thing is the unpredictability. You know, and that's why they're watching them all the time, because, you know, well, okay, today they're not quote unquote wandering, tomorrow they might be. Today they're not falling, tomorrow they might be. And then you've got the repetitiveness, you've got, you know, you have a number of things. But cognitive was one. What was second? Incontinence. And then third was the anxiety and depression, hard of hearing, stroke, and then vision. You know, and I had some others that also fell in, but those were the main ones. Now, the xeric burden, you know, and that we're asking the patient also, or the caregiver, to rate what their relationship, we're really rating their relationship and how caregiving has been burdened. We're asking them to rate their own burden, okay? And so I guess the caregiver burden started out like with 29 questions, and then it dropped to 22, now it's at 12. We've got one that's 4. And the 4 are 1, 2, 5, and 10. And if you rate those 4, it's just, how would you say it, Dr. Powers?
just a screen.
It's a screening, but the difference between the 12 or the 22 and the 4 questions, minimal. I mean, you can find out if there is some depression or burden based on those 4 questions. Yes, ma'am.
I have a question. So, how difficult do you find that it is to get at these conversations with families? Because I've definitely had families who, like, you try to go down this road and they immediately are like, it's not about me, it's not about me, it's about the patient, like, I don't care about me. And, like, you have a very hard time even, like, broaching that conversation. It takes multiple visits. So, like, how do they respond? Do they respond to, like, a piece of paper? Does that feel less invasive to them? Or?
I think that's less, I think it is less invasive, but it's not as intimidating, because they can be kind of anonymous in asking those questions. And then the other thing, because I ask them over the phone. I've got a couple of caregiver classes or sessions that I do, and they often will be honest, you know, and especially when they know that this is something that is ongoing. You know, it's the more honest you are about it, the more healthy you're going to be. And I think a lot of times, and that's what I have that's going to be in a couple of slides further down, is that you are someone that they really highly respect as the doctor, and especially with these older patients, whatever you say, they are going to take it to heart. And even if there are a lot of roadblocks up initially, because there is this attitude, you know, caregivers have an attitude, I can do it.
Mm-hmm.
They can be falling apart, but I can do it. And, you know, we have to develop those relationships, and it's, you know, and even though you may only have, are you going into geriatrics?
No, I'm PD.
You're PD, okay.
But I
Well, even with families,
numerous
okay.
times, you know, you just
Right.
can't get to it.
Right.
And,
But sometimes it takes more than one visit too,
Yeah.
you know, because it's relationship building and it's a trust issue. You know, if I tell you how I really feel, well, you think I'm bad, you know, and I think that a lot of times we want people to think really highly of us. We want people to think we're good people. And if I tell you the truth about how I'm really feeling, I'm sick and tired of taking care of this person, you know, and when you give them permission to be honest, you know, and sometimes that's a development, you know, and so, but that's the goal though, because you want them to be honest, and because you want them not to be invisible, and you want them to get the help that they need. So, you know, the whole purpose is just showing you these are just different tools that you can use that would be very helpful in really kind of assessing. And you know what? They don't even tell the truth on these. I mean, I get them, I talk to them on the telephone, and a lot of times, is, you know, because of the time you spend with your relative, you don't have enough time for yourself. Oh no, you know, I have enough time for me. No, they don't. They're probably at a 4, because it's nearly always they're following them to the bathroom. You know, they can't get they're on the telephone, they're saying, why aren't you, they're sitting there looking really sad and pitiful, because they want all of their attention. They cannot stand to be separated from them. And that is that can be really overwhelming. So, just understand that you may have to do the zero burden more than one time, to get the truth. Yes, sir.
Two questions, which is, one is, do you get into this, so you have kind of the invisible patient and the visible patient. Do you ask these questions in front of the visible patient? Meaning, like, do you get different answers? Do you speak to them separately? And then the other one is are there members on the team that seem to be better at getting the information out than others? Because I find sometimes, for me, when they meet with me, it's like, oh, everything's great. Mm-hmm. And meanwhile, I just heard you in, like, Marty or Benetta's office, having a whole discussion about, all the problems that are going on.
Right. And you're right. Because sometimes they really see that separation. You're the doctor and you're my husband's doctor, and but one of the things that you can do is just by letting them understand, or letting them know that you understand, that they may feel more comfortable talking to the social worker. You know what? That's okay. But one of the things that you may still want to do is get some information, make sure you're getting information from them, so that when you're in your team meetings, that you can get the whole dynamics, you can get the whole picture. So as long as someone is working with you and getting that type of information, and that caregiver's being supported, that's all good. It's all good. So that was a great question, because you're right. Some of the patients may work, interact better with some than others. So, okay. Did I answer your question?
Yeah.
Okay. Yes, ma'am.
I guess, excluding dementia, you think it's helpful to discuss these things with the patient and the family member together, so that if there are struggles that maybe the patient's not aware of, that they can, like, behavior issues, or I don't know, or is that kind of make a difficult dynamic between the two?
Well,
kind of like along the lines of what he was saying, but
the only thing that I would question is if you're talking to the family member, and I personally, depending on what stage, like especially if there's dementia involved, it would really kind of depend on what stage they're in. A lot of times the person with dementia may not get it.
I'm talking about, like, people without dementia, like maybe somebody's got end-stage COPD, but they're mentally there.
Sure.
But they require a lot of care from, like, their spouse or somebody. I mean, is it better to maybe facilitate those conversations with the patient and their caregiver so that the patient understands, or is that, I guess it just depends on the dynamic?
I think it probably it depends on the dynamics, but I think one of the things that would, if they're clear and you can share what your expectation is. Now, whether they're hearing the same thing that the caregiver is saying, so that when the caregiver goes home and it tells them, well, the doctor said blah, 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 everybody heard the same thing. And that's when you're not dealing with someone with dementia. And I think that it can certainly go both ways, but I'd probably feel pretty comfortable talking if I had a particular medical, the word that I'm trying to say, if I want the family to go in a particular direction with that particular patient, I'd probably include them in that discussion, so that everybody is on board, and maybe try to verbal contract with the patient that he's going to follow, these are my orders. Can we do that? Because if they're not going to do it, they're not going to do it, whether they're in the room or not. But I think that to show them respect, I think it's a good idea to have them, if they can, I would have them in the room and do a verbal contract with them. Does that answer your question? Okay, that has, we already talked about the 4 screen questions, the 12 questions. That's the one that I use. Intervention for caregiver burden is like discharge planning. You start when the person is admitted to the hospital in discharge planning. You begin interventions when the person is diagnosed. There has to be education about the disease process, whether it's diabetes, heart disease, end-stage renal, or dementia. Share the prognosis of the disease. What are they looking at? How long do they think it's gonna, how long is it gonna go for? May or may not be relevant, I mean, like with dementia, depending on when it was diagnosed, it may be a later stage than you think. But you don't, again, collaboration, like a potluck, everybody brings something to the table. So again, going back to you, Dr. Fisher, he may not be the perfect person. It may be your social worker, it may be your nurse, it may be your tech, it may be someone, but as long as the information that you need, you get got, it's good. Recommendations, as far as, and these are, again, interventions. Identify the high-risk caregivers, education about the disease process, share the prognosis, make them part of the team. A lot of times the caregivers stay invisible because they don't really understand what's going on. We have a tendency to talk over them or not involve them in what's going on. And some of the caregivers, it's not necessarily on purpose either on your part. Some of them just don't really want to know because they're in denial of where they think that if they give the right vitamins, if they are the best caregiver, then they're going to do better. The patients are going to do better, and that's not true. But encourage them to journal, and the reason I encourage journaling is because not only they can get their feelings down, but if something happens, they need to be able to tell you. You can tell them what type of things you want written down so that when they come in and there's a new behavior or a new whatever, and you ask them, when did that start? And they really can't give you any idea of when I think it was 2 weeks ago, and I think it was at such and such a time, and what were the circumstances. If they journal those things, then all of that can be captured. Provide resources to new caregivers. Offer trainings for complex medical care. Encourage advanced planning when caregiver can no longer provide the care. Offer caregiver support and respite services. Remind the caregiver they're not alone. And so what I mean by especially provide resources, get familiar with the resources that are available. Just like in that resource catalog, that's here in San Antonio, but a lot of cities have those. And so it's important to do that. Familiarize yourself with these particular resources also, like Stress Busters, the Alzheimer's Association, the Agency on Aging, which with the VA, we have a big relationship with the Agency on Aging, which is called ACOG here. Alternative placements. When does hospice and palliative care fit in? Because a lot of times, we catch them when they're in hospice. But now that we've got this wonderful palliative care program to support families, let's utilize it. So they don't have to be in stage last year or 9 months for them to get some of the help that they need and the support that they need. A geriatric care manager for those that may be out of state, especially. If the families are out of state, they might need someone to help manage mom or dad. And so you can't do that as a doctor, but someone else can, and you'll be working with them as well. Adult protective services, when they're living by themselves, they need not to be living by themselves, but sometimes you're in a position that you're finding out some information that are really places them in a dangerous situation. So, all of these others, fall prevention, geriatrician, pharmacist, audiologist, all of those things, familiarize yourself. Promote caregiver self-care, the breathing, all of those things that can give the caregiver a sense of being, rather than being joined to the hip with this other person and not being, taking time for themselves. That is so important. Make a doctor appointment or a dental appointment and keep it. I was talking to a lady yesterday. She was telling me she didn't know when was the last time she went to the doctor, because she's trying to get her husband situated first. Are you crazy? It's like going to, like you're on an airplane. The oxygen drops down from the ceiling. And, the caregiver is, they tell them to put the oxygen on yourself first before you put it on somebody else. What does the caregiver do? They're all over the place, putting oxygen on everybody, including the one next to them. And when the plane lands, where's the caregiver? Dead. And that's what happens with these people, a lot of times. And I don't mean to say it in a condescending manner, these people, but you know, the caregivers, often they're neglected. Guide the caregiver into revealing their fears and concerns. There are no surprises, there shouldn't be any surprises because you're telling them what to expect. So when they reach a different plateau, they should not be surprised. You know, they'll appreciate your care and concern towards them, provide them with guidance on how to communicate with you. Sometimes, you know, that we get so much into the internet and we want them to send us a message. Some messages can't be conveyed by email. And so maybe if you've got at some point you might have a caregiver that might need a little bit more. So try to hook them up, and not you, don't give them your home number. Do not give them your cell number because they will be calling you. But if you can connect them with someone that, or an organization, I tell people call the Alzheimer's Association. There is a 1-800 number, you can call them anytime, day or night. They're 2, 3 o'clock in the morning, you can call them. So that's something like that. Establish contact with social workers, psychologists who will be able to join you in supporting the family. Finally, listen to their concerns about their loved one. Encourage the caregiver by letting them know they're doing a great job. You know, they're gaining weight or they're still the same, their A1C is good. You know, just try to encourage them to do that. And encourage them also to take care of themselves, take advantage of the respite, their doctor appointments, healthy diets, help provide or help in their stress, to help them to de-stress by providing them with resources, the social worker, the nurses, those folks that can direct them. Okay, now I'm not going to do questions because I want to show a little bit of this caregiver interview that I had to go and get. So I got a captive audience and I'm going to show you some. Can you hear it okay?
Hi, my name is Valerie Taylor and I'm a registered nurse. I want to talk to you today about caregiver burden. I have a tape or a clip from an interview that I did with my mother-in-law, who was a caregiver of my father-in-law before he passed away. She had been caring for him about 4 years, was diagnosed with vascular dementia. He had other comorbidities like congestive heart failure, as well as diabetes, and he was insulin dependent. As a result of that, she experienced a lot of burden, stress, and it was very difficult for her at times to deal with the situation, feeling very hopeless and helpless. Caregiver burden is real. It causes illnesses for the caregiver. The caregiver needs help, and oftentimes we are not able to identify that because we're really not looking for it. So, as you're watching this interview, please take these things into consideration when you are dealing with your patients as well as even your loved ones. That caregiver burden is real. We want to be able to keep them at home by identifying the burden and giving them resources and the help that they need so that they'll stay in the race so that the system will not become inundated with all of these people that need care on our system, on our healthcare system. And it is going to be a problem with this silver tsunami that's coming, or that not only is coming, it's here already. So watch with me. As a caregiver, you know, what are some things that have been helpful for you? Because we know that the stress and the burden is really high on caregivers because it's a 24/7 job. And so what are some things that have been helpful for you to care for yourself, not necessarily care for them? Because I know that you have done a wonderful job taking care of your husband.
Well, you have to pray. You have to pray for strength, I know that. And going to church was helpful. Being around people was helpful. Sometimes even when the grandkids would come over, they could entertain Charlie and Charlie could entertain them and they loved him. And it takes his mind off of himself and gave me a chance to do other things, get on the computer, stuff like that, while they played little games with him. When we used to play cards, dominoes, when you and Charlie were coming over and we would play games and all that was helpful. As long as he was busy doing something, I think it helped me. Sometimes I would get some of these movies that he liked or videos that he liked and put them on. He could really get into them. After a while, that didn't even work, you know. So, when he was going to the adult daycare, that was very helpful. He enjoyed it. He felt like he was at a job, like he was working. He enjoyed going there. It just got to a point where he was requiring more attention than they could give him because he couldn't do anything for himself after a while. But initially, that was a big help. Gave me a couple of days where he would be going. And even when he had physical therapy, I would go with him and I would sit there for an hour while he had physical therapy. But he enjoyed interacting with people. He enjoyed the physical therapy. So, those kind of things were very helpful.
It was difficult for you to send him into respite. And you had promised that you didn't want to do that again. So what do you think, how could you have been supported in that time, even though it was really difficult with taking care of him and things like that? What do you think, what other kind of support do you think that you could have been given and not having to send him out? Was there anything that could have been done?
I don't know, because he really didn't want anyone else, he or Charlie, and sometimes Stephen, my other son. But, you know, when people come from home health care, he really didn't want them there. So it was a necessity that I leave for a little bit, but I just didn't feel like I could do it again because I was away, but I was worried about him the whole time, and they told me every day, every morning, he was disoriented and he was saying, get my wife on the phone, call her, tell her to come get me. And that, well, I couldn't enjoy myself. And so when I come back, and I was so anxious to see him, to see if he was okay. And he says, don't do that again. And I said, I won't leave him again. But that's just my case. I think people do need that respite care. They do need a break. I felt good in a way. You know, I felt like I really needed a break, and I was ready to keep on with him and do everything I had to do again when I came back. In the hospital, in the rehab, and sometimes at home, I would make sure I made him eat by feeding him. And he could probably have done it himself because he was doing it around people if I wasn't there. But I was there.
Now, why, in your mind, when you think about it, what was your rationale for doing it?
Well, because he was diabetic, and I wanted to make sure he ate. And one time I went to the hospital, and they said he didn't eat much breakfast. And I said, well, was anybody helping him? And they said no. So I said, okay, I'll be here to make sure. And so I would spoon feed him. Because he would just let it sit there, you know, and when I fed him, he ate every bit of his lunch or dinner. So, to me, it was an easy thing to do, but I think he could have been lazy. Because he told me sometimes, no, I'm so used to you doing it. But I think if they can feed themselves, let them. That was just,
Yeah. But you know, that kind of helped him, remember also, because I would really probably say that, he's probably not being quote unquote lazy, but that was a kind of a reminder to him that we really have to eat. Say if you are, just like when you and Pop used to eat dinner together, he'd watch you eat, and so that would encourage him to eat. But oftentimes in the hospital that we have, he was eating alone, so there was no prompting. So, you know, that you probably did the right thing, because yes, even though he could, that prompting would have reminded him, you know, to eat, so.
yeah.
You know, some of the behaviors that were kind of difficult, it would take forever for him to get his bath, or going on, sitting on the toilet.
Nerve-wracking, because he would sit in there and he was, I gotta take a shower, I gotta take a shower. And I said, I was afraid for him to get in the shower if Charlie wasn't there to help him. And I begged him, let me just wash you. Sit on the tub and I'll wash you from head to toe. And he would eventually let me go ahead and wash him. But if Charlie was there, then he could give him a shower. He was insisting on getting that shower every day. He couldn't find the handle to the shower. He couldn't find his toothbrush. He couldn't find his toothpaste. It just was getting steadily worse. And I don't know, I just didn't know how much he was going to decline, you know. Then I prayed that he would get to a point where he couldn't swallow. I prayed about that, and God did not let him get to that point.
And he was also able to continue to do his own insulin and take his medications.
Yes, I would give him the medication. And almost to the very end, he could give himself the insulin. But then he would give it to himself in the stomach. I would give it to him on the finger. I would take the blood, and then he would do it in his stomach. I insisted on it. I didn't want to stick it in his stomach. So he would do it.
But that was helpful for him as well, because it allowed him to continue to participate, be an active participant in his healthcare.
Yeah.
And so that was really very good. You know, that was great.
Yeah. And what the doctors all said was every time he came to the doctors, they would say, well, how are you doing? I'm fine. He never complained. They didn't know he was as sick as he was, because he would always say, I'm fine. You know, he just never complained. It was amazing. I would take my Bath and Body Works stuff, and have the candles, and I would have a glass of wine, or half a glass. And sometimes I would read my book. I do love to read. These are relaxing things. And it's necessary to have something to do by yourself that you enjoy. And then I would watch the funny stuff, because I didn't want to watch anything serious. So I would watch The Golden Girls and Frasier at night. Get a few laughs, which is very important, to have something to laugh about. Sometimes Charlie would even watch it with me if he was awake. But that was all part of the relaxation.
You know, I found, and just changing the subject a little bit, there was so much love that I saw between you and Pop. It was just so tender. And even though sometimes it was the repetition or having to redirect him that sometimes just really was frustrating at times, there was still that bond. There was that relationship that your 50 million kisses. And you laughed.
He didn't want to, I would say to him, are you depressed, honey? And he said, no, I got a good wife. And he knew that he was so loved.
Mm-hmm.
You know, he knew that. And I could feel the love from him when he saw me. He brightened up. Was he brighten up when he see you too? But I always felt loved, and I always loved him so much. So, when you love somebody, when you care, you need to just about anything for them.
So that's it. I'm gonna. That is my story, and I'm sticking to it. I hope that your takeaway will be that you want to see your patients as well as their caregivers. And my point wasn't that you have to do everything, because you don't. But you gather your team around you that can help so that those caregivers' needs are being met, in some way, shape, or form. And again, here at the VA, we have so many resources that we can utilize for them. And outside, if you're planning on going out in the community, find out, are they a vet? That's one of the first questions, because if they are, you can steer them over to the VA to get some services. Anyone have any questions? That's all. Thank you so much for coming.
All right, anyone wants a copy of the PowerPoint, just go ahead and let me know. And make sure you sign in if you want credit for today's presentation.
Hanging on the grandma.
Well, that's the hard part now. Somebody wants to
One of them's not working now, right?
Yeah, sometimes there will be space.
But all the fellas here.
Okay.
I was going to say, I didn't even know where it was. I'm like,